What if physical therapy isn't downstream anymore? What if we were the first contact, delivering faster answers, smarter triage, and better outcomes because we are equipped with point of care diagnostic tools and the training to use them responsibly? Today, I'm breaking down a brand new Frontiers article on first contact primary care physical therapy practice, and I'll connect it directly to the hands-on diagnostics primary care physical therapy residency we have filed to build the next generation of first contact clinicians. Here's the uncomfortable truth. The healthcare system is strained. Provider shortages, long waits, rising costs, and musculoskeletal complaints are a massive chunk of primary care demand. The real question is not whether physical therapy can lead here, it's whether we are going to show up with the training, pathways, and diagnostic clarity to make that leadership undeniable. We'll talk about this and more in just a moment. Stay with me. Welcome back to Your Practice, Your Money, the show where clinical success meets financial freedom. I'm your host, Dr. Dimitrios Kostopoulos, and if you are getting value here from these episodes, please subscribe on Apple Podcasts, Spotify, or wherever you listen, and leave also a quick review, because this helps more practice owners and clinicians to find this show. Today is one of those episodes that it's not just interesting, it's directional. It's about where physical therapy is going and how the practices that move first will build the future. Well, today I'm using one powerful article as the backbone of our discussion. The article is called Advancing First Contact Primary Care Physiotherapist Practice, the Value of Integrating Point-of-Care Diagnostic Tools. It was written by Nathan Savage, Richard Nielsen, Art Nitsch, our very own Dr. Mohini Rawat, and Bruno Steiner. And you can get a copy of that if you go to yourpracticeyourmoney.com. I'm going to connect also this article directly to the hands-on diagnostics new position statement, for which I dedicated an entire episode. And most importantly, the reason we filed our hands-on diagnostics primary care physical therapy candidate residency, to create a real training pathway for physical therapists who want to practice at that first contact, primary care level with modern decision making. This article starts first with the big picture. Healthcare systems worldwide are facing shortages in primary and specialty providers, rising direct and indirect costs, limited access to diagnostics and interventional services, especially in rural and underserved areas. And then it makes the key claim that expanding the role of physiotherapists as autonomous first contact providers is a timely innovation to meet those pressures. This is exactly why the HODS position statement frames primary care physical therapy as the profession's next necessary evolution, not a marketing phrase, but a healthcare necessity. The article further reinforces what serious primary care looks like. autonomous evaluation and diagnosis, intervention and discharge without medical referral in systems that support it, improved access and reduced time or financial barriers for patients. It also points out the practical reality in the United States. Well, direct access exists pretty much everywhere, with many states having no restrictions at all, meaning the infrastructure is already here. But here's the pivot. If we are going to be accepted broadly as first contact primary care providers, diagnostic reasoning must be elevated. And in many cases, that means advanced tools are no longer optional. The article is blunt that skilled use of interpretation of advanced diagnostic tools is likely necessary for widespread acceptance. That is why the hands-on diagnostics position statement says it clearly. Primary care is not just a role, it is a responsibility. Here is one of the most important lines in the article, conceptually. Many clinically based tests and measures don't have enough diagnostic power to create meaningful shifts in probability. So when uncertainty persists, instrumented point-of-care diagnostics can change the game. And the authors identify two core tools physical therapists can integrate through recognized pathways: electrodiagnostic testing, EMG nerve conduction studies, ultrasound imaging, including musculoskeletal ultrasound. The article describes electrodiagnostic testing as an extension of the clinical examination that evaluates neuromuscular function in real time and supports differential diagnosis and targeted referral. It describes also point-of-care ultrasound imaging as safe, cost-effective, and dynamic, useful tool for tendons, nerves, fusions, soft tissue injury, and much more. There's a really nice visual actually on page 5 called Figure 1 there on how electrodiagnostics and ultrasound imaging plug into the clinical pathway, like history and screening, clinical exam, diagnostic testing, stronger differential diagnosis, then prognosis, plan of care, and appropriate referral and better outcomes. Now let's connect this directly to hands-on diagnostics, because our position statement and everything we've been talking about the past 13, 14 years says it in a way practice owners can operationalize it. Diagnostics are not about doing more tests. They are about making better decisions faster with the right tool at the right time. The article also makes a major point that exposure in entry-level programs rarely equals proficiency. And to truly modernize practice, we need competency-based education, hands-on skill development, progressive assessment, and postgraduate pathways. And it actually lists barriers that sound familiar to every clinic owner: lack of structured training, equipment costs, reimbursement variability, institutional support, scope ambiguity in certain regions. Here is the moment to be very direct. If physical therapy is going to claim first contact primary care leadership, we must build formal training infrastructure, not weekend confidence. That is exactly why hands-on diagnostics filed with ABPTRFE a candidate residency program in primary care physical therapy to prepare clinicians for modern first contact practice where diagnostic tools support differential diagnosis, risk identification, and efficient care pathways. This is the bridge between the vision in the Frontiers article and what actually happens in the clinic Monday morning. Because primary care, after all, is not just a label, it is a capability. The article discusses cost effectiveness. Direct access, for example, reduces redundant visits, unnecessary imaging, medication use, and keeps care efficient without increasing adverse events. Our hands-on diagnostics position statement adds the practice owner lens that outpatient PT must achieve also more equitable payment aligned with expanded responsibility. Earlier detection and faster clarity reduces delays, inefficient episodes, unnecessary referrals, expensive imaging, and avoidable chronicity. And then the part practice owners feel immediately that diagnostic-enabled services can create sustainable outpatient models because the value and reimbursement structure can be fundamentally different when done correctly and responsibly. This is not about abandoning therapy. This is about building an integrated model where therapy remains the foundation and diagnostics add clarity, efficiency, and value. The hands-on diagnostics primary care physical therapy candidate residency is designed for physical therapists who want to lead first contact, musculoskeletal and neuromuscular triage, practice with modern pathways and higher level clinical reasoning, integrate point of care tools responsibly when uncertainty persists and diagnostic clarity changes management. In other words, this residency program is a direct answer to what the article that I'm referencing here calls for robust postgraduate training pathways that modernize the profession and strengthen our case as a true primary care discipline. Remember this. Number one, the world needs more first contact musculoskeletal care, and PTs and the PT profession is positioned to deliver it. Number two, first contact credibility requires diagnostic precision when uncertainty persists. Number three, electrodiagnostics and musculoskeletal ultrasound are point of care tools with real pathways and real value. And finally, number four, training infrastructure is the bottleneck. So we are building this infrastructure through the hands-on diagnostics primary care physical therapy residency. If this episode sparked something for you, share it with one clinician and one practice owner. This is how a profession changes, one standard at a time. And if any of you would like to meet with me and discuss strategy, please click the link below, the link that you see on your screen. Schedule a meeting with me and we can strategize together and we can go over your specific clinical practice and clinical pathways that you are interested in pursuing and how this can change your physical therapy practice, both clinically and financially. And again, please subscribe on Spotify, Apple Podcasts, and wherever you listen. Reviews help more leaders find this show. See you next week with another very important and interesting episode. Until then, keep building clinical success and financial freedom. Take care, everyone.